The prognosis of unresectable or recurrent gastric cancer remains poor, and immunocheckpoint inhibitor, especially PD-1 blockade, shows some efficacy in later lines of treatment. So this CheckMate 609 study was planned to investigate chemotherapy plus nivolumab as an anti-PD-1 therapy, or nivolumab plus other immunocheckpoint inhibitor, CTLA4 inhibitor ipilimumab, or chemotherapy alone in first-line setting. So as a primary analysis after 12 months of minimum follow-up, a first-line nivolumab plus chemotherapy demonstrated superior overall survival as well as a PFS benefit, which led to approval of this Nivo plus chemo in several countries and changed the standard treatment. So in this ASCO GA meeting, we reported an expanded analysis of efficacy and safety after the minimum follow-up of 24 months, which was 1 year longer than that of interim analysis. So this CheckMate 609 study is an open-label, globally conducted randomized phase 3 trial. And as mentioned before, in this ASCO GA presentation, we mainly reported updated analysis of chemotherapy plus nivolumab versus chemotherapy alone. And here, more than 1,500 patients were randomized to these two arms, regardless of PD-L1 expression as CPS score. And among them, around 60% of patients had PD-L1 CPS5 or higher. As a main result, clinically meaningful improvement in overall survival and PFS with nivolumab plus chemotherapy was maintained in this longer follow-up. Actual 2-year survival rates were 28% with nivolumab plus chemotherapy and 19% with chemotherapy. We also reported PFS2, which was defined as time from randomization to progression after the first subsequent therapy, initiation of second subsequent therapy, or death, whichever occurred earlier. And there was an improvement in PFS2 with 25% reduction in risk of death or disease progression on subsequent therapy. And then looking at the subgroup analysis, overall survival favored nivolumab plus chemo across all key subgroup with consistent result in patients with PD-L1 CPS5 or higher. And when analyzing efficacy in various PD-L1 CPS subgroup, overall survival benefit with nivolumab plus chemo was enriched at a higher CPS cutoff. Overall survival hazard ratio was 0.69 in patients with CPS5 or higher versus 0.94 in patients with CPS less than 5. Of note, objective response rate were higher with Nivo chemo versus chemotherapy regardless of PD-L1 CPS status, and these responses were deeper in waterfall plot and more durable with a combination. The safety profile of Nivo chemo was consistent with the known safety profile of each agent and in line with the previous report at 12 months of follow-up, and we don't identify no new safety signals. I believe these results further support nivolumab plus chemotherapy combination for its use as a standard first-line treatment in patients with advanced gastric, GEJC, or esophageal adenocarcinoma. So very importantly, additional biomarker analysis is already ongoing, and I hope it may give us additional insight about optimal population for this combination. So as mentioned before, already this Nivo chemo is approved in several countries, including US, Japan, or other countries. And this indication is regardless of PD-L1 CPS status, so it has all comers. On the other hand, this chemo Nivo is mainly recommended for patients with PD-L1 CPS5 or higher population according to NCCN guideline because we observed different magnitude of survival benefit according to CPS subgroup. Also, this chemo Nivo is only approved for CPS 5 or higher population in EU countries. So this combination is definitive or most recommended treatment for patients with PD-L1 CPS 5 or higher, but there are some controversy for its use in CPS less than 5 population. However, as shown in this presentation, some patients with CPS less than 5 achieved a favorable outcome since we have a higher response rate even in this population. So clarification of this population by additional biomarker might be very important work. So I just want to mention that still several trials of immunocheckpoint inhibitors are ongoing in gastric cancer field. For example, immunocheckpoint inhibitor in combination with multikinase inhibitors such as lenvatinib or regorafenib is under investigation in phase 3 trials. Furthermore, several perioperative trials of checkpoint inhibitor are also still ongoing and will be reported within a couple years. So please stay tuned.